And so questions. What questions do you have? Throw them into the chat window, or you can hit the space bar if you want to turn your video on so I have somebody to look at other than my unshaven face. That would be great. What does NVD stand for? It's a great question. Nausea, vomiting, diarrhea. So with a gastric disease, antiplatelets ruin the lining and cause more bleeding. That is a very simple way of saying you're really close. Yeah. So when you have gastric stomach issues, you want to be careful about giving antiplatelets and NSAIDs and steroids. So antiplatelets, because a lot of your antiplatelets are also NSAIDs, non-steroidal anti-inflammatory drugs. So you want to be careful about antiplatelets, you want to be careful about NSAIDs, and then you also want to be careful about steroids themselves, because any of your anti-inflammatory drugs also affect the gastric lining of your stomach and can lead to bleeding. Perfect, excellent. For the blood typing slide, which way do you look at, across or up and down? All right, so let me scroll up to the blood typing slide. So I'm going to look at the one down here in the bottom left-hand corner. It's a matter of matching them up. It's not which one do you read first, it's where they connect. So you can honestly look at it both ways, because you could say, well, you have donor blood. So if I donate my blood, I'm O positive. Who can that go into? So then you'd look down from the donor O positive, and you would see that it could go into any positive blood, because O can go 0, can go into any blood, but the positive can only go into positive. So that's why O positive, still a good blood to have, to give, to donate, but it can only go into positive. Now, some questions might look at it from the other side. You have a patient who comes in from a motor vehicle accident and they need a unit of blood, and their blood is A positive. What kind of blood can they get? Well, you have to think about what can go into A. 0 can always go in, that's automatic. And then A can go into A. B can't go into A. So that's why when you look at the A positive, you have O negative, O positive, A negative, A positive, because if I'm A positive, like that's my blood, I'm the one that's dying on the table, I can get negative blood because it's not existent. The element isn't there. It's a negative, not there. I could also get it when their blood has the element, because I have the element. So I can get negative and positive. I can always get O blood, that anybody can get O blood, but then I can only get the A. So I cannot get A, B, because I can't get the B part into myself. And I can't get B because B will interact with my A. So that's how you process that. If you remember that O negative is the universal donor, meaning O can go into anybody and negative can go into anybody, that's a good start, because then you can work your way towards AB positive, which is the universal recipient, which means if I'm the recipient and I'm AB positive, I can get O, I can get A, I can get B, I can get negative, I can get positive, I can get it all. So you can look at it from that way as well. what is the difference between PT and PTT? That's like saying, what's the difference between potassium and calcium? They're just different values. They're different lab values. Now, they both deal with clotting, but potassium and calcium both deal with heart function too. They just deal with it differently. So it's a good thing to compare and contrast. They both, PT, PTT, are both lab values that evaluate clotting time, bleeding, but they're dealing with two separate factors, so they're different in that regard. And again, it isn't, I had another question with, everybody's seeing these too. Can you go over the differences between PT and PTT and INR? PT is your heparin. And let me draw something for you. I always like to be able to draw now and then. Hey, Cole, you're getting a little loud. Don't make me come over there and drop the hammer on you. I just drew PTT. Can somebody tell me what looks uniquely helpful in identifying what drug that might go with? Looks like an H, right? PTT goes with heparin, okay? Now, there isn't anything to draw with the INR or the PT that tells you to go with warfarin, but the PTT goes with heparin, the PT and INR go with warfarin. Now, even though the PT goes with warfarin, most commonly you're looking at the INR value. It's just an easier, more specific lab value to the administration of warfarin. APTT and PTT, if you see either of them, they're very close to being the same thing. They're not, but for all intent and purposes, the values are relatively similar, and what they're looking at is still the heparin dose. Why do we measure INR for warfarin and PT? Okay, so we measure INR and PT for warfarin, and we measure PTT for heparin. We just do. That's the lab values that it goes with. I appreciate the question, but if somebody has been eating a lot of bananas, we're going to look at their potassium level. Why? Because that's what's in the banana. Or if somebody's been urinating a lot, we're going to be watching for their sodium level and their renal function, because that's what it's connected to. INR and PT are connected to warfarin as a drug lab value, and PTT is connected with the heparin as a drug lab value. Can you review the agranulocytes and the MPS? So let me scroll up here. So monocyte, if you went back to this screen here, you'll notice that there's monocytes. Monocytes are phagocytotic. So they're eating things, kind of like the neutrophils. They get in there and they break stuff down and it kills, the bacteria. So there's different elements. Some of them have granulocytes and some of them don't. That's how they're made in the body. Mononuclear, one nucleus, I guess is kind of phagocytic system. So just in general, the monocytes are used to eat up bacteria, to dive in, go, oh, you don't belong here, I'm going to chew you up and spit you out. That's what they do. And then there's different, like, oh, I keep updating it. They mature, the monocytes mature into either macrophages or lymphocytes. So the macrophages are in the tissues, and I guess you could say somewhat the bloodstream, and the lymphocytes are your T cells, and B cells. So they are lymphocytic. So macrophages are tissues, somewhat the bloodstream. Lymphocytes are in your lymph system and in your blood as well. So the B cells is in the blood. Cool. Other questions? Make a reminder to get your quiz in. All the instructions were sent out today again. Password, it's in the email. Make sure that's in, I believe it was tomorrow. I don't remember what time. Somebody, did I say noon? Did I say midnight? Noon. So tomorrow by noon. Get that in. Other questions? Intrinsic, extrinsic clotting. That's not it. What are you talking about? Is that on, what slide is that on? There it is. All right. So intrinsic and extrinsic, it's in the slide as to what's going on. The extrinsic pathway is external trauma. So a knife, a gunshot, you fall down and you land on a stick and it punctures your body. That's extrinsic. That's external trauma to the blood vessel. And then internal damage to the blood vessel, intrinsic pathway, is things where you weren't necessarily traumatized by something damaging outside the body, but your body goes through a lot of trauma itself, the whole aging process. And you can have internal damage to a blood vessel just through body's attempt to remain in homeostasis. There can actually be internal damage, even like platelets. Platelets can cause damage, or maybe your bleeding times are off. You ate too much vitamin K. You ate like 6 pounds of spinach and caused some clots to form, and those cause damage. So that's really what it is. It travels along some different pathways. So be it. It still ends up in the same spot as a clot, fibrin. So other questions? Did you want the tally sheet to have the answers for all the quiz questions, just the ones? As far as the tally sheet, you can, if you used it to write stuff down on at home, that's fine. Turn it in. If it only had 6 answers on it, because that's all we did in class, that's fine. Turn it in. I just want it turned in. That's all. All right, so we're going to do a couple practice questions, then I'm going to go through a couple case studies. Hmm. Mm-hmm. All right. So here's what's going to happen. I'm going to make it so that you're only answering with me. So whatever you put in the chat window at this point will only be coming to me. So when you're reading a question, this is why I'm going to do a couple of these. It's really, really important that you think about an answer before you see the options available to you. So try and change this a little bit. There we go. No, that one's a little complicated. How about this one? All right. So I want you to read the question, and then in the chat window, I want you to throw down a couple things that come to your mind as to what it could possibly be. So I'm seeing some people say folic acid. I'm seeing some people add in iron. I'm not sure where the iron's coming from. Somebody explain to me where the iron's coming from. What do we give iron for? We give iron when they have iron deficiency anemia. Does this person have iron deficiency anemia or bleeding? Are they bleeding? And so if that answer is no, then don't throw new stuff at because you feel like, oh, there's got to be more than just folic acid. No, not really, because Crohn's disease is not typically a bleeding disorder. It's a absorptive order, and it is inflammatory in nature. Now, if you thought of folic acid and B12, now you're getting, I could see where the B12 would come into play. Except, did they say that they had pernicious anemia? Anybody? If you don't see it, then it's not there. Now, Crohn's disease is a GI disorder. Does anybody know where the GI disorder is at? GI is gastrointestinal. So is Crohn's commonly a stomach problem or an intestinal problem? It's an intestinal problem. It might also involve the stomach, but 90+% of the time it starts with the intestines. So it's more of a intestinal issue. So that sort of takes the B12 off. Either way, the most obvious answer, even if you thought of a couple different answers, folic acid and iron, folic acid and B12. Which one's the definitive one? Yeah, folic acid. This is where a lot of students get tripped up. They think, oh, well, folic acid seems too obvious. So I'm going to second guess myself and go with the second answer that I thought of, because that's where the trick is. He's not going to get me, except I'm not trying to get anybody. I'm trying to say, if this is the problem, what would you do? I'd like to know what you would do. So you have an idea. So now go ahead and tell me what answer you would pick. A, B, C, or D. Oh, sorry. 1, 2, 3, or 4. Now, in the answers, you should be reading all of them before you pick one. Some of you, if you're going to call me trying to get you, it would be in the answers of 1 or 4, because now I have 2 folic acid answers, which means you're like, oh, if you didn't read all of the answers, you might have just been like, oh, 1, that's it. That's what I thought of. Jim taught me how to do this right. I'm going to pick 1 and then move on. It's not what I said. I said, know what you are looking for and then read all of the answers and see which one best fits. This is where the Crohn's disease comes into play, because oral folic acid is not going to be absorbed well when you have a GI disorder. So therefore, we need IM folic acid so that we get our dose. So 4 is our best answer for how we get the folic acid. All right, next question. Okay. Thanks for listening to the rules of the house. I appreciate it. Builds confidence. Builds confidence. Respect. I appreciate that. Thank you. Starting school back is hard. New rules, not summertime rules. All right. So give me an answer. Sickle cell crisis symptoms. Remember, all the words mean something. Sickle cell crisis symptoms are related to the anemia and essentially it's saying what's causing the symptoms. The anemia is causing the symptoms, and some people are saying hypoxia or hypoxemia causing the symptoms. Okay. Some people are saying clotting causing the symptoms, pain causing the symptoms. Okay. Well, what's really causing the symptoms? 1, 2, 3, or 4. The crisis symptoms are based on clotting. Remember, I talked about in class, all those microclots, all those mini heart attacks all over the body that's causing the pain. The clots are causing the pain. The pain is the symptom, not the cause. So pain can't cause the symptom because pain is the symptom. Hypoxia isn't up here as an option, but that could be a part of it. But even still, the clots are what are causing a lot of those symptoms. Now, what caused the blood to clot? The hypoxia caused the blood to like sickle in shape and clot, and then you end up with all the symptoms of crisis. Oh, vasoocclusions was the correct answer, because vasoocclusion, that's the clots. Occlusion, clots. So if I were to go back here and get rid of the answers, because I think some of you may have just like went back to your old habits. And oh, the answers are there. Let me read the answers. Maybe those will help me pick out my answer. They won't. You want to start with what's going on. So you have a 28-year-old sickle cell anemia being admitted for vaso-occlusive crisis, which means they are in sickle cell crisis without shortness of breath. Interesting symptom to be saying isn't present. Okay, which intervention should the nurse implement first? Well, if they're not short of breath, then they don't need oxygen first. They will. But what is almost always the first thing to do with sickle cell crisis? Pain is the priority, but pain meds are not the priority. Because remember, you want to do hydration first, which gets rid of the pain or can mitigate the pain. So we want to do fluids. Yeah. Narcotics will be administered, but they're not. Read the question. It says implemented first. It's HOP, hydrate, oxygenate, pain meds. Now, what if I said the same question, but they had shortness of breath? Vaso-occlusive crisis with shortness of breath and SATs of 78%. Then it would be 3. Right. Now, sitting up the head of the bed might help a little bit, but it is not helping a vaso-occlusive crisis, life-threatening scenario. They are super deoxygenated. Their SATs are 78%. We need to actually give them oxygen. So, yeah. Now, here's a tricky thing in the answers that are there. Technically, if I were to say vaso-occlusive crisis with shortness of breath, there still isn't a good answer, because elevating the head of the bed isn't going to be enough to help somebody in that situation. And administering 2 liters of nasal cannula is also not going to be enough to help them out. It's still give them fluids, because you'd want a non-rebreather mask, 15 liters. That would be the oxygen we'd need. Now, I did have a good question, but don't you need an order from the physician for oxygen? Yep. And because it's an answer, that means we have an order for it. And that's how every question is written for future reference. This is really important. I get this question all the time. Don't we need an order for those things? You'll never see it written in a question until you get to some really, really high level questions. You're never going to see it written order for O2 and administer, or received order for morphine 2 milligrams PRN IV every 2 hours, received from the doctor and administer. If it is an answer written 1, 2, 3, 4, 5, 6, whatever, if it's one of the answers, then you already have the order for it. You just have to decide which one is the best. So if the question said the patient had shortness of breath, 3 still would not be the best answer, truly, because it's not effective enough. We'd want to give oxygen, but 2 liters isn't enough oxygen to make it worthwhile. We'd want to give a non-rebreather 15 liters, 100% mask. Let me put it into this situation. Somebody comes in with 50% burns all over their body, and they're super hypovolemic, because that's what you die from burns in the early stage. And one of the answers said, administer normal saline at 25 milliliters per hour. The concept is we need to give them fluids, but you also have to give them the right amount of fluids. 25 milliliters per hour is considered keep open for people that don't really need fluids. So in answer of give that burn victim an IV at 25 milliliters an hour even though the concept of giving fluid is present, it's not the right amount. We'd want to give boluses of fluid. We'd want to give liters and liters of fluid to that person. 25 milliliters an hour is not enough. Does that help? I know we're doing this virtually, but does that help? Like, it has to be the right concept, but also the right overall answer. So in this situation, whether they're short of breath or not, of the answers present, the answer would only always be number 4, whether they're short of breath or not, because the other answers just aren't enough. Let's see here. All right, there we go. We'll do a couple more, and then I got a couple case studies for you, and we'll call it a night at 9:30. Hop method only applies to sickle cell. That's a very specific interventional strategy for sickle cell. Good question. So you need to be thinking about, what are you going to do? Because when you walk into a patient's room, you're not going to have multiple choice answers to select from when you're taking care of people. So this is the way that you read questions so that you don't get tripped up. You've got information. What are you going to do? And you might come up with a couple possibilities. That's fine. Got 41 people. I'm going to wait for a few more answers. I got like 5. So whatever answer you are sending me right now, none of them were exactly worded the same, but the concept of what most of you are saying is relatively close. So now there are really only 2 possible, like if I get rid of the answers, there's only 2 things that should be thought about at this moment. Okay, they're on warfarin. It's an anticoagulant that it affects the INR. So I'm going to, INR is way high. Okay, there are 2 answers for that. Stop the med, lower the dose, or give vitamin K as the antidote. That's it. Because you're already getting too much warfarin. So we need to lower the dose, stop the dose. That's one thought. Or give the antidote. So I'm going to look for one of those 2. IV fluids has nothing to do with it. Oh, prepare to give our antidote. That's a possibility. Notify the healthcare provider to increase the dose. No, it's already too high. We want to decrease or stop. So that's out. And then administer medication as prescribed. Nope, because we're already too high. So then you end up doing number 2. Warfarin goes with the INR. Heparin goes with the PTT. All right. So I want to let everybody know here, and whoever's watching at home later on, all of those questions and others that we didn't go through are actually posted to Module 1 in Blackboard, and they are listed. I'll even show you on the screen here. Let me share screen. Under Module 1, down here it's listed as active learning exercises, practice questions, and you'll see a PowerPoint. Now, I do not open up these practice questions until after the tutoring session. So I opened them up just before the tutoring session, but I knew you were here. But those will be opened up every week, the week of the exam. So next week, Module 2, we'll have some practice questions, and Module 3 will have some practice questions, but both of those modules, practice questions won't be open until the Tuesday of exam week, which would be week 4 in that situation. After the review session that we hold for it. So you can go in there, you can download those, you can do the practice questions. The answers are in the notes section of the PowerPoint with each of the slides. But I encourage you to practice reading the question without answers present and trying like, okay, where's this going? What would I do? What are a couple of things that I might possibly have answers or thoughts about the concept for the answer? Like with that warfarin one, the dose is, it's too much. They're getting too much of it. So we need to decrease it, stop it, or give the antidote. Where's that answer? Oh, there it is. And none of the other ones are even close. So I'm going to pick that answer and move on. You have to think through the questions that way before you see the answer on the screen. Now, on your exam, you won't have that benefit, but you will have scratch paper that you can rip in half if you want and have a half sheet put up over, the bottom of your screen so that you cover your answers. And I do this with the 2s, the 4s, and anybody else that asks. I've done this with my kids who are like, Dad, I just don't understand how to process these questions. Well, let me show you how to read a question. Cover the answers. Think about what you know and what you would do in that situation. Come up with a couple thoughts, and then you look for that answer. And if you have a couple different answers that are, close, you got to go back and reread the question and see if, kind of like that Crohn's disease one. Well, oh man, there's 2 folic acid answers, oral, IM. How do I decide? I go back to the question. Is there anything else in the question that now might help make more sense with picking between these answers? In that case, GI disorder, not going to do an oral drug for a GI disorder. I mean, conceptually, that way. So that's now available to you. And I do want to take a couple minutes to do some case studies. These are not released. I pretty much just do these in class and during tutoring session, but I'm going to post this up here. Anytime you're thinking through a case study or even a question, what assessments might I need to get if there aren't assessments yet? What diagnosis are the symptoms? If there is assessment pieces, what's the diagnosis then? And once I have the diagnosis, what am I going to plan to do about it? What meds might I give? What treatments might I do? And then if I've already done treatments for the diagnosis, then how would I evaluate it? How would I make sure it was therapeutic? How would I make sure they're getting better? How am I going to know that they're not getting worse? Like what's the evaluation of it? So that's what you want to be thinking when you're reading case studies, reading questions, nursing process. Are there assessments in this? And do they point me to a disease yet? Yes or no? If they do, then you don't need to get more assessment. You need to diagnose. And then if there's a diagnosis, then what are you going to do about it? And if you've already done something about it, how are you going to reevaluate that? So You read through this. Is there enough information for you to determine a diagnosis, or do you need more assessment? And go ahead and in the chat window, just send me some thoughts about the case study you see before you. And you might not even see it yet because I don't think I'm sharing the right screen. How about now? I do love finding pictures. Man, it's fun. So, do you need an assessment? If so, what might you want to assess? Do you have a diagnosis? If so, what would it be? Okay, some of you getting a little bit nitty gritty and picky on the picture. Yes. Would that help you? Oh, that was just fun. I normally leave it in there, but so yeah, we'd be looking at perfusion, we'd be looking at bleeding, we'd be looking at pain. We want to focus on our pulses and our, numbness and tingling and neurologic functioning. Probably not going to have a whole lot of it based on how traumatic of injury that is. Now, what kind of anemia, if they had an anemia, would it be? Iron deficiency, yes. Now, hypovolemia is more of a concern, but to go after the content of our lecture, my lecture, it would be iron deficiency, yes. All right, so for this patient, donor blood options for somebody that is O positive. The patient, they're O positive. What kind of blood can they get? And before you hit enter, try and put them all in one chat. So comma, 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 when you get them all, hit enter. Now remember, we're dealing, the recipient is O positive, which means they can only get O negative, O positive. If they were donating, if this person with the O positive was donating, then they could donate into O positive, A positive, AB positive, B positive. But for them, they can only get O negative, O positive. The rest of it interacts. How about A negative? The patient's blood type is A negative. O negative, A negative. Excellent, because O blood can go into anybody, all right? And this person's A negative, so they can get O negative. They can't get any positives, and they can't get any Bs. So they can't get AB, they can't get B, but they can get O and A. So O negative, A negative. Patient's blood type. They can get everything. Love it. Excellent. All, everything. Beautiful. So what's probably going on here in terms of the concepts that we're talking about from week 1? Got to be more specific than that, Michaela. Really, there's only one. I mean, in terms of anemias that fit, we're dealing with iron deficiency anemia. Chronic, long-term menorrhagia is difficulty or problematic menses. So we're saying that that person has symptoms of mild fatigue. So they have symptoms of being iron deficient with their menses. So we've got iron deficiency anemia. Now, the person who's got a traumatic injury, is ferrous sulfate oral tablets going to help this person? Versus, is ferrous sulfate tablets going to help this person? Yeah. So we want to give them iron, but how we give it and what amounts we give it and the form we give it, that does change, even though the diagnosis is the same. In terms of what we've been focused on in this class so far, 1 week, 1 day, what is your thought process on this patient? Yeah, it's going to be B12 because we got stomach cancer. We've had a gastrectomy, meaning a removal of their stomach, even though the picture is more of a bariatric procedure. Gastrectomy was the removal of it. So we're dealing with vitamin B12, pernicious anemia. How are we going to treat it? The special sauce, intrinsic factor. I love it. Yes, you no longer have the intrinsic factor, so you're going to need to do an IM injection of vitamin B12. What are some symptoms we would want to watch for in this patient of pernicious anemia? Yeah, because B12 deals with the nervous system, so you're watching for numbness and tingling and pins and needles and that kind of thing. If they're really now, if somebody had pins and needles and numbness and tingling, what would we do? What would be our treatment? Yeah, we're going to give them the vitamin B12, right? Because that's a symptom that they don't have enough of it, so we're going to give it then, not IV. It's IM B12. We've done sickle cell already. We've done sickle cell. Okay, here we go. What's going on here? Yep. We want to live in high altitudes to help them train for it. What disease process? And it's not a disease process at that point. It would just be a natural process, but that would be polycythemia. Excellent. How about this one? What's going on here? So once again, it's polycythemia. Same issue, but driven by two different processes. And actually, it's still the same process. What does living at a high altitude and having COPD have in common? Hypoxia, right. So are these primary or secondary polycythemias? Because they're both dealing with hypoxia, so it's the same thing. These are secondary. What would primary be? How do you get primary polycythemia? Tumor. Tumor of the bone marrow, tumor of the kidney, a tumor. Now, chances are that polycythemia from COPD or living at a high altitude is not going to create enough red blood cells where you have a problem. It's just, you have more red blood cells. Okay. The problem child is the primary. When you have a tumor, that's going to just exponentially create red blood cells without any limits. So that's the one that you end up having to do more treatments on. All right. So I think this was super productive. I hope the hour and a half helped clarify some of the meds, as well as doing questions, doing the case studies. Hopefully in class, we'll have a little bit more time once we settle into the flow of the semester to do some more practice questions in class, to do some more case studies in class. But yeah, thank you for hanging out with me tonight. My kids are not appreciative. No, I'm just kidding. I told them they know Tuesdays every few weeks, dad disappears at night. So any questions before we shut down here? I have a couple flowing in here. Thank you for all the appreciation. Is StudyMate required or is it a helpful tool? It's just a helpful tool. There's no assignments. I don't track it. I don't look at anybody to see if they're completing it. But if you are having trouble understanding the words that are being spoken, then it would be a really helpful tool. So, is the video going to be posted? Yes, I'm going to render the videos, both of them, and then I will be posting them to YouTube with a link located in the module, actually the tutoring. There is, let me show you. That's there. Get this out of the way. Okay. So the tutoring recordings are going to go right here. Can anybody see where my cursor is? I don't know what you can see. All right, cool. So the tutoring recordings will just be thrown right in there. Exam 1, exam 2, exam 3. Now, once I have done the video, you'll actually see like a YouTube video or link right in that box. All right, have a great night. Thank you, you too. Can you explain INR real quick, like the definition? So INR definition isn't super important in terms of it's a ratio between the PT and PTT with some other math that's thrown into it. What the most important aspect is, as that number goes up, they bleed easier, and it's related to warfarin. So INR is really just a ratio and some mathematical calculations, but the answer of that ratio, whatever it is, whether it's 1.2, 2.7, 5.9, like that tells you where we are in terms of risk for bleeding and medication therapeutic levels, that kind of thing. Are the drug cards supposed to be on those papers? Yes and no. I'm all about giving students some flexibility as long as you complete the assignment. So if you want to take those columns, the titles of those columns, and you want to put those onto a drug card and have individual drug cards, great. If you want to add more columns, like more side effects, more adverse effects, more contraindications, you want to add some columns, that's fine. Go for it. That document, the information that I'm asking for is the minimum. If you want to do more, that's great. If you want to do it on some other document, that's great. But that's the minimum expectation. Cool. All right. Well, you guys have a good rest of your week. And I will see you Friday morning, 9:30. We will start the exam, and right around 10:20, we will be starting class. So, yeah, I will see you on Friday. Have a good one. Adios.